Welcome to this Step 2 clinical knowledge review on pregnancy complications in the first half of pregnancy. This video is brought to you by Roadmap to Residency. Today, we are breaking down the most common question patterns you will see on your board exam for ectopic pregnancy, spontaneous abortion, Hyperemesis Gravidarum, and Gestational Trophoblastic Disease. The goal here is not to reteach every detail, but to help you recognize question stems and apply test-taking strategies that get you to the right answer quickly. Make sure you have reviewed the obstetrics chapters in First Aid and your question bank before or alongside this video. Let us get started. Here is what we are going to cover today. First, we will learn to recognize the high-yield question stems for first-half pregnancy complications. These are the classic presentations the boards love to test. Second, we will apply specific test-taking strategies for ectopic pregnancy, spontaneous abortion, Hyperemesis Gravidarum, and Gestational Trophoblastic Disease. Third, we will practice the next best step question format that you will see repeatedly on exam day. Before we dive in, make sure you have reviewed the obstetrics and gynecology sections of First Aid and your question bank. This video is about strategy, not about learning the material from scratch. We are here to sharpen your test-taking skills. Our first strategy is learning to split ectopic pregnancy from spontaneous abortion quickly, both present with first trimester bleeding and pain, but the question stems give you specific clues. For ectopic pregnancy, the buzzwords are sharp or sudden unilateral lower abdominal or pelvic pain, amenorrhea, and vaginal bleeding. They will often mention risk factors like prior tubal surgery, pelvic inflammatory disease history, or intrauterine device use. The classic setup is a positive pregnancy test with no intrauterine pregnancy seen on transvaginal ultrasound. For spontaneous abortion, the key is that an intrauterine pregnancy has already been confirmed. The stem will describe vaginal bleeding with or without cramping, and the differentiator is the status of the cervical os. Threatened abortion means the OS is closed and there is still fetal cardiac activity. Inevitable abortion means the OS is open. This split comes up constantly on the boards, so train yourself to look for these clues immediately. Our second strategy is splitting Hyperemesis Gravidarum from Gestational Trophoblastic Disease, also known as molar pregnancy. Both can present with severe nausea and vomiting, but the question stems give you key differentiators. For Hyperemesis Gravidarum, the stem will describe persistent nausea and vomiting with weight loss, ketonuria, and electrolyte imbalances. The patient is typically dehydrated and unable to keep anything down. The management is intravenous fluids and antiemetics. For gestational trophoblastic disease, the boards love to describe a uterus that is larger than expected for dates, a very high beta-human chorionic gonadotropin level, and a snowstorm or cluster of grapes pattern on ultrasound. They may also throw in early preeclampsia before 20 weeks of gestation or signs of hyperthyroidism, both of which are red flags for molar pregnancy. When you see these combinations, think gestational trophoblastic disease immediately. Now let us talk about high-yield stem recognition. These are the classic setups you need to spot instantly. For ectopic pregnancy, the stem gives you a woman of reproductive age with amenorrhea, unilateral pelvic pain, and vaginal bleeding. The pregnancy test is positive, but there is no intrauterine pregnancy on transvaginal ultrasound. They often include risk factors like prior pelvic inflammatory disease or tubal surgery. Watch for hemodynamic instability, which pushes you toward surgical management. For spontaneous abortion, the stem describes first trimester vaginal bleeding in a confirmed intrauterine pregnancy. The entire question often hinges on whether the cervical OS is open or closed. Closed Os with fetal cardiac activity is a threatened abortion. Open OS is inevitable or incomplete. For gestational trophoblastic disease, they describe a uterus larger than dates, markedly elevated beta-human chorionic gonadotropin, and the classic snowstorm ultrasound. They may add hyperemesis, hyperthyroidism, or preeclampsia before 20 weeks as bonus clues. Train yourself to identify these stem patterns quickly. Here is our first practice question. Read the stem carefully. A 26-year-old woman presents with sudden onset left-sided pelvic pain and vaginal spotting. Her last menstrual period was 7 weeks ago. The urine pregnancy test is positive. Transvaginal ultrasound shows no intrauterine pregnancy and a complex adnexal mass on the left. Vital signs are stable. Serum beta human chorionic gonadotropin is 3,500. What is the most appropriate next step in management? Take a moment to think about what diagnosis this question is pointing you toward and what the key factors are that will determine management. We will walk through the answer on the next slide. Let us walk through this answer step by step. Step 1. Spot the pattern. We have amenorrhea at 7 weeks, unilateral pelvic pain, positive pregnancy test, no intrauterine pregnancy on ultrasound, and a complex adnexal mass. This is a textbook ectopic pregnancy. Step 2. Apply the rule. For ectopic pregnancy management, the key decision point on the boards is whether the patient is hemodynamically stable or unstable. Our patient has stable vital signs, which means we consider medical management with methotrexate. The boards want you to know that methotrexate is appropriate for unruptured ectopic pregnancy in a hemodynamically stable patient. Step 3. Eliminate wrong answers. Expectant management is not appropriate when there is already an adnexal mass identified. Laparoscopic salpingectomy would be correct if the patient were unstable or if the ectopic had ruptured, but that is not the case here. Dilation and curettage is for intrauterine pathology, not ectopic pregnancy. The correct answer is B, methotrexate. Review the ectopic pregnancy management algorithm in your obstetrics resources for the full criteria. Here is our second practice question. A 32-year-old woman at 9 weeks gestation presents with moderate vaginal bleeding and lower abdominal cramping. On pelvic exam, the cervical OS is open and tissue is visible at the OS. Ultrasound shows retained products of conception within the uterus. What is the most appropriate next step in management? Think about the classification of this type of abortion based on the OS status and what you see on ultrasound. We will walk through the reasoning on the next slide. Let us classify this abortion type and walk through the answer. The STEM gives us an open cervical OS with tissue visible at the OS and retained products on ultrasound. This is an incomplete abortion. Here is how the boards classify spontaneous abortions, and you need to know this cold. Threatened abortion has vaginal bleeding, but a closed cervical OS and fetal cardiac activity is still present. Inevitable abortion has an open OS, but tissue has not yet passed. Incomplete abortion has an open OS with some, but not all tissue passed, and there are retained products on ultrasound. Complete abortion means all products have passed, the OS is closing, and the uterus is empty on ultrasound. Missed abortion has no fetal cardiac activity, but the OS is closed and no tissue has passed. In our question, the open OS with retained products means incomplete abortion, and the management is suction curettage. Expectant management carries too much risk with active bleeding and retained tissue. Methotrexate is for ectopic pregnancy, not for intrauterine retained products. Cervical cerclage is for cervical insufficiency and has nothing to do with this scenario. The correct answer is C, suction curettage. Review the abortion classification table in your obstetrics resources. Let us review the key management points for Hyperemesis Gravidarum and Gestational Trophoblastic Disease. For Hyperemesis Gravidarum, the boards want you to know that the first step is intravenous fluid resuscitation. A critical pearl is that you must give thiamine before any dextrose-containing fluids to prevent Wernicke encephalopathy. This comes up on board questions. The classic lab findings are hypochloremic hypokalemic metabolic alkalosis from all the vomiting. Ondansetron is the commonly tested antiemetic. For gestational trophoblastic disease, the treatment of a complete molar pregnancy is suction evacuation of the uterus. After evacuation, serial beta-human chorionic gonadotropin levels must be monitored to ensure they return to zero. The boards love to ask about the need for reliable contraception during the monitoring period, because a new pregnancy would cause beta-human chorionic gonadotropin to rise and confuse the picture. If beta-human chorionic gonadotropin levels plateau or rise after evacuation, this suggests gestational trophoblastic neoplasia, which requires further workup and possibly chemotherapy. Review the Gestational Trophoblastic Disease chapter in your obstetrics resources for the full classification. Here is our third practice question. A 24-year-old woman at 10 weeks gestation presents with persistent nausea and vomiting for 3 weeks. She has lost 8 pounds and cannot keep down any food or liquids. She appears dehydrated with dry mucous membranes. Urine shows ketonuria. Her basic metabolic panel shows hypokalemia and hypochloremia. What is the most appropriate initial step in management? Think about what the labs and clinical picture are telling you. We will walk through the answer on the next slide. Let us walk through this answer. The classic pattern here is persistent vomiting, significant weight loss, ketonuria, and electrolyte abnormalities including hypokalemia and hypochloremia in early pregnancy. This is Hyperemesis Gravidarum, and it is beyond simple morning sickness. The patient is dehydrated and has metabolic derangements. Now for the key distinction. Oral ondansetron will not work in a patient who cannot keep down anything by mouth, so giving an oral medication does not make sense as the initial step. Ginger supplements and dietary modification are appropriate for mild nausea of pregnancy, but are completely inadequate for this severity. Termination of pregnancy is not indicated for Hyperemesis Gravidarum. The correct answer is B, intravenous fluids with thiamine supplementation. The thiamine pearl is critical for the boards. Always give thiamine before dextrose-containing fluids to prevent Wernicke encephalopathy. This is a commonly tested concept. Review the Hyperemesis Gravidarum management algorithm in your obstetrics resources. Here is a critical test-taking pearl about beta-human chorionic gonadotropin monitoring. The boards love questions where the trend in beta-human chorionic gonadotropin levels determines the correct answer. In normal early pregnancy, beta-human chorionic gonadotropin roughly doubles every 48 hours. If the levels plateau or rise abnormally slowly, the question is pushing you toward ectopic pregnancy or a non-viable intrauterine pregnancy. If the question tells you the level is above the discriminatory zone and transvaginal ultrasound shows no intrauterine pregnancy, that is ectopic until proven otherwise. After molar evacuation, beta-human chorionic gonadotropin should decline steadily to 0. If it plateaus or rises, that indicates gestational trophoblastic neoplasia and requires further workup. The boards test the trends and patterns more than they test specific numeric values. Focus on understanding the clinical significance of rising, falling, or plateauing levels in each clinical scenario. Review the beta-human chorionic gonadotropin monitoring guidelines in your obstetrics resources. That wraps up our review of first-half pregnancy complications test-taking strategies. Let us recap what to focus on. Review the obstetrics and gynecology chapters in first aid and your question bank. Pay special attention to ectopic pregnancy management algorithms, the spontaneous abortion classification table, hyperemesis gravidarum management with the thiamine pearl, and gestational trophoblastic disease workup and monitoring protocols. Practice as many questions as you can on these topics in your question bank. The more stems you see, the faster you will recognize these patterns on exam day. If you found this video helpful, please like and subscribe to our channel for more board review content. And if you want personalized tutoring or residency advising, check out our expert team at roadmap2residency.com. We are here to help you succeed on your boards and match into the residency of your dreams. Good luck on your exam.